Now I welcome Professor S.P. Dhaneria to continue on this topic of management of tobacco dependence. Professor Dhaneria is an MD in pharmacology and DM in clinical pharmacology and LLB also, and he has special interest in teaching pharmacology for a very long time, and we would like to hear from him. He is also our dean here at AIIMS Raipur and has been the organizing secretary and the heart and soul of NAMS Con 2016. Welcome, Dr. Dhaneria.
Honorable chairpersons and distinguished delegates. In this presentation, I shall be sharing with you in next 15 minutes some of the views on the pharmacotherapy of tobacco dependence. Nicotine, which is present in tobacco, is a ganglionic cholinergic agonist, and its repetitive exposure will lead to neuroadaptation and dependence. In early stages, there may be only slight psychic dependence when one is taking 10 cigarettes per day without inhalation, mild psychic dependence. But if use is more, say 20 cigarettes per day with inhalation, there will be slight physical dependence with moderate to severe psychic dependence. And heavy use of tobacco will lead to significant physical dependence and severe psychic dependence. There are two basic principles in the management of nicotine dependence: psychotherapy and pharmacotherapy. When pharmacotherapy is coupled with psychotherapy, then we will get best results. The pharmacotherapy is indicated only when a person is willing to quit the smoking or use tobacco in any form. Pharmacotherapy has no role if person is not willing to quit the tobacco in any form. The aim of therapy is to suppress the withdrawal syndrome, because whenever one quits the smoking, there are unpleasant manifestations of withdrawal syndrome, which may be restlessness, anxiety, depression, inability to concentrate. There may be increased appetite, weight gain. So, we have to suppress the unpleasant manifestation of withdrawal syndromes by some medication. And second step in the management is to prevent the relapse, maintain high abstinence rate. So, we reduce the craving for smoking or use of tobacco in any form by other set of drugs. So, for the management of nicotine dependence, the first line medications are nicotine replacement therapy. Nicotine replacement therapy, here various formulations are available. For oral, we have the nicotine chewing gum, nicotine lozenges, sublingual nicotine. For inhalation, we have nicotine spray, we have nicotine inhalation, and also we have the transdermal patch. Another drug which is effective is bupropion from the antidepressant class of drug, and varenicline. So we have various formulations of nicotine. These formulations will provide some amounts, maintain some level of nicotine in the body, and therefore suppress the withdrawal syndrome. And gradually the amount of nicotine in these formulations is reduced, and in this way we achieve the abstinence. So considering one of the commonly used is the nicotine chewing gum. If one is taking less than 25 cigarettes per day, 2 milligram chewing gum is indicated. And if one is consuming more than 25 cigarettes per day, 4 milligram chewing gum is advocated. Person is asked to chew the chewing gum for about 30 minutes whenever there is an urge to smoke, and not more than 24 pieces per day are recommended. This schedule is followed for about 3 months, and then we gradually reduce the amount of the nicotine in chewing gum and then discontinue. The person is advised not to take acidic foodstuffs during chewing the gum, because the substances like tea, coffee, fruit juices, soft drink interfere with the absorption of the nicotine from the buccal mucosa. Another formulation is nicotine spray. 0.5 milligram is sprayed in the nostril, each nostril. Requirement may be minimum 8 inhalation, 8 sprays per day to the maximum of 14 per day, and that is continued for about 3 to 6 months, and then the doses are reduced. Then we have a transdermal patch. It is applied as soon as a person wakes up on the quit day. Whenever one decides to quit on that day, it is applied on non-hairy skin for about 16 to 24 hours. So for first 4 weeks, daily the patch is applied containing 21 milligram of nicotine. Then for next 2 weeks, the dose is reduced to 12 milligram. For next 2 weeks, the dose is further reduced to 7 milligram. So in this way, the nicotine patch is applied on the non-hairy skin, and if the patch is interfering with the sleep, we can remove in the night. So then the duration of application of patch will be 16 hours, otherwise for round the clock we can apply it. Another is the nicotine lozenges. 2 milligram lozenges if a person normally smokes first cigarette 30 minutes after the awakening. And if a person normally smokes first cigarette within 30 minutes after awakening, 4 milligram lozenges is recommended. Not more than 20 lozenges are recommended per day. Usually this practice is followed for about 12 weeks, means 3 months, and then we gradually reduce the doses. When we talk of nicotine preparations, we should be very cautious of using the nicotine replacement therapy if the person is of uncontrolled hypertension, untreated peptic ulcer, or having the recent history of stroke or myocardial infarction. Another drug is bupropion. It is an antidepressant drug. It actually blocks the reuptake of dopamine and noradrenaline. It can be started 2 weeks before the stoppage of smoking. It is started in the dose of 150 milligram once a day for first 3 days, and then twice a day, and it is continued say around 7 to 12 weeks, up to 3 months. And then if we are getting the desirable effect, we can further continue for 3 more months, and then we gradually reduce the dose. Bupropion is a drug which takes care of weight gain following the cessation of smoking. It takes care of the depression after the stoppage of smoking. But it should be avoided if patient is having the seizure disorder, having some eating disorder like anorexia nervosa or bulimia. So these we can say contraindications to use of bupropion. Varenicline is the partial agonist at nicotinic receptor. Like bupropion, it can be started 1 to 2 weeks before the stoppage of smoking, 0.5 milligram daily for first 3 days, then twice a day for next 3 days, then 1 milligram twice a day for the 12 weeks or 3 months. We can continue for further 3 months, and then we gradually reduce the dose. There is a concern of neuropsychiatric adverse effect with the drug. It may cause, in addition to nausea and vomiting, disturbance in driving capabilities, convulsions, and suicide ideation. Also, some cardiovascular events are reported with the use of varenicline. But the benefits of cessation of smoking outweigh the risk involved with the use of varenicline. If first-line drugs are not much effective, like nicotine replacement therapy, bupropion, or varenicline, we can rely on the second-line drug, clonidine. It's alpha-2 agonist, and it reduces sympathetic drive from locus ceruleus. We can use it orally, we can use it by transdermal application, but we should be very cautious while using this drug. Abrupt withdrawal may lead to rebound hypertension. In addition, it is causing sedation, dryness of mouth, and some cases of depression are reported. Nortriptyline is another antidepressant which has some role in management of smoking cessation. It is inhibitor of noradrenaline reuptake, and it is also used in the dose. We start from 25 milligram per day and increase up to 100 milligram per day for 3 months, and then we can gradually discontinue it. 2 more drugs have come, and in various studies, the promising results have been shown. One is mecamylamine, that is non-competitive nicotinic receptor antagonist. Being the indirect antagonist, the chances of withdrawal are less, but it improves the abstinence. Another is naltrexone, opioid receptor antagonist. It is believed that some of the pleasurable effects of tobacco are opioid mediated, and therefore, if we use opioid receptor antagonist, we can reduce the craving for smoking. There are a number of agents or methods which have shown some effect, some favorable effects in studies, but their efficacy is still uncertain. Like it has been said that in early phase of withdrawal, we can use the anti-anxiety drug, diazepam, propranolol, buspirone, because that will moderate the withdrawal syndrome. Cystine, it is actually a plant product from which the varenicline has been derived. Salicyline, MAO-B inhibitor in Parkinsonism. Citric acid inhaler, they are also tried with some success, but more extensive studies are needed to prove their efficacy. Silver acetate has been tried as aversion therapy. This silver acetate actually binds with the sulfide of smoke and produces bad taste. So it will be a sort of aversion therapy. Acupuncture has also been tried to moderate the withdrawal syndrome. We know that acupuncture actually releases endorphins, and endorphin acts to opioid receptor, and in this way, probably acupuncture may moderate the withdrawal syndrome. 4 vaccines are under trial. The vaccines are developed in order to produce the antibodies. These antibodies will bind the nicotine and prevents its entry into the brain. And that's why we are blocking the pleasurable effects of nicotine. These are under trial. 2 vaccines are in phase 3 and 2 are in phase 2 trial. If we look to the tobacco dependence, tobacco consumption is one of the leading cause of preventable diseases and premature death. Tobacco consumption imposes significant financial burden on healthcare providers. Therefore, if we implement the tobacco cessation strategies, they are more beneficial than we are putting our financial resources on the diagnosis, prevention, and treatment of illnesses. That's why there is a consensus that because the financial burden involved in the diagnosis and management of the illnesses is much more than the implementation of tobacco cessation strategy. And therefore, consensus is that tobacco dependence treatment is both clinically effective and cost effective relative to other medical and disease preventive measures. So when we decide to implement the tobacco cessation program, we are, there is a basic principle that psychotherapy is the integral part in the management. Pharmacotherapy is coupled with psychotherapy in order to obtain the maximum outcome. And when we decide pharmacotherapy, our first line will be the nicotine replacement therapy. We can add bupropion to that, but in that situation, we have to carefully monitor the blood pressure of the patient. And we have the varenicline. If first line are not effective, then we can rely on the second line that include clonidine and naltrexone. So to conclude, the good political commitment, awareness and participation of public, proper implementation of health program, and policies to discourage tobacco use and promote cessation are cornerstone in the success of tobacco cessation program. Thank you, ladies and gentlemen, for kind attention.
Okay, thank you, Professor Dhaneria, for complementing the earlier lecture.
Yes.
And for surgically dissecting the mechanisms which are involved in the various compounds which are used for cessation therapy. So, topic is really good, which has been explained in more details. But if there are some queries, comments, please ask. Yes. You can come much closer.
Hello. Sir, my question is to Lokesh, sir.
Lokesh.
Dr. Lokesh.
Sir, frequently while taking personal history, we most of the time come with the problem that patients are unaware of addiction or insight of addiction. Sir, what we can do to make them realize? So the problem is that whenever we talk to them, they say, नहीं यार वो नहीं, अगर मैं सुर्ती नहीं लूँगा तो मेरा सुबह का मोशन नहीं होगा. And this type of vague things they say. Sir, then we just smile and just say our part. Sir, what we can do during that time? So that's the thing we want.
So our job start with the very fact that we need to elicit that someone is taking a substance. So first is that he should admit, and then you need to assess that why there are so many roadblocks. Like if he says that he has problem in passing motion, okay, so then you can suggest that this is because you develop a dependence over a period of time. Now because of your ongoing process of taking tobacco, okay, then you should tell him that what is the relevance of him being stop using the tobacco. He must be visiting to you for some other reason, no? Like if you're in your OPD, he's visiting to you for some other reason. You tell the relevance, his personal relevance. If he lives taking tobacco, what is the relevance? What kind of risk he is having, and what kind of reward he is getting if he is coming away from it. And then you suggest that there are some ways by which you can come out of it very easily, with help of some kind of medication, with the help of some kind of psychotherapy or psychotherapy support. You can come out of it, and you can tell there are so many person who is coming to us with this problem and they are coming out of it. Okay, so first and foremost that you have to have a confidence that this thing can be cured, this has got a solution, and then you can offer the solution to the patient. Okay.
Thank you, sir.
You had said that when the patient is quitting the tobacco addiction, he must talk to his family and friends to tell them that he is this thing. When suppose he is not quit and he is still continuing with his addiction, do you counsel the family? And if you counsel the family, what are the kinds of instructions that you give them?
Okay. So, sir, the very slide you are talking about is basically concerned with those patients who are willing to quit, and for them these are the supportive measures that they can take. In the situation where patient is not willing and the family members are accompanying the patient, so they can be taken as a co-therapist in that process, that we talk to the patient, make them a co-therapist. Like patient is with us only for 15 or 10 minutes, Okay, we tell our concern, we pass on all the information that we have to the patient as well as the family members. And then it is the role of family member that they try to pursue him to come again for the treatment. So that how he comes in the treatment loop. So the first and foremost thing that patient should be in treatment loop. Then only we can offer him help. So that is how we proceed, sir.
What do you do? What do you tell them to do at home?
We tell the patient like no all those things like relevance, the risk, the reward that he is going to have, and these things should be told to the patient, and then they will try to convince that doctor has told so many as things. At the same time, they can give some examples to the patient. They can tell about some bad outcomes of those who are taking tobacco. So these are the ways and means by which they can pursue the patient to come for the treatment. And at the same time, some kind of emotional bonding they have, which physician and patient don't have. So they can use those bonding also. Some kind of, you can say, the emotional pressure, you can say, that they can put on the patient so that he can change his mind. Sir.
First of all, let me compliment you and your team
Thank
for
you, sir.
taking this initiative. Most people are rather scared. Rather pointed question. In your experience in this institute, what is your success rate for quitting? And for how many patients and for how long?
Sir, talking about tobacco, it's very common. And
What is the quit rate? I mean, at the end of 6 months, 1 year, 5 years, what is your experience?
yeah, talking about experience, are like those patients who are well motivated. And
Of total patients, what is your quit rate? That's what I'm asking.
yeah, if you're talking about for last 1 year, I have been in so many number of patients, what is the quit rate? So I would say the most conservative estimate is around 40%, sir. 40%.
40% have quit and you followed them for 1 year.
Like usually, sir, these patients are not coming only for tobacco. Tobacco being a part, like the patient who's coming with the depression, some patients are going to dental OPD.
If you are
then being
doing
referred-
40%, I mean, I would love to share your experiences with other people, because even in the best of places, as I was talking earlier, it is normally in single digits. So I would like you to just make sure that your figures are right. And if you're actually at 40% at 1 year, and you have a good number of people, you should write it up. That is my suggestion.
Thank you, sir.
Are there any de-addiction centers for
Sir, we are offering these services from our OPD. Like we are offering this kind of services.
like for example, if a person is there are regular spas or places where these patients get admitted and they are looked after, maybe 3 months, 6 months or whatever. Are there similar kinds of de-addiction centers in India?
As such, India, there are so many centers are around, sir. Like both in the private sector, in the NGOs and the government center also, there are so many addiction centers around. Like here, as of now, we're talking about AIMS Raipur. We are offering OPD service at the same time we are admitting the patient for short term. So we are mainly doing with the detoxification part and part of psychological intervention that we can offer them, because rest of the team member like clinical psychologists, social workers, and trained nurses are not with us right now. In the coming future, sir, we have planned to start separate addiction blocks, so that we can offer this kind of help. And we're also running a kind of special clinic for opioid dependent.
OPD. See,
And we're running.
I've got a question to ask you like this, that OPD is fine.